Greetings to everyone. This is Dr. Shamla Ravikumar, Professor and Head Department of Oral Pathology, Adiparashakti Dental College and Hospital, Melmarottur, State of Tamil Nadu. My topic for today's revision is developmental disturbances. For convenience sake, I have just divided it into developmental disturbances of hard tissues and developmental disturbances of soft tissues. Now coming to the developmental disturbances of hard tissues. In the beginning, we'll just go through the craniofacial anomalies and a small gist about the craniofacial anomalies, how they are formed. Now, development of craniofacial region is a complex process reflecting strongly evolutionary forces controlling the morphology. They comprise a broad group of deformities caused by genetic or environmental factors. Usually, they are present at birth and they may be mild or severe in expression, causing anatomical and functional derangement. The craniofacial anomalies being craniosynostosis, hemifacial microsomia, vascular malformations, and deformational plagiocephaly. But the most common craniofacial anomaly concerned to dentistry are the cleft lip and the cleft palate. Now, one of the key features of craniofacial development is the formation of the cranial neural crest cells. Cranial neural crest cells are important pluripotent cells derived by an interaction between cells of the neural plate and the adjacent surface ectoderm. The cranial neural crest cells forms most of the hard tissues of the head, for example, the bone, cartilage, and the teeth. Hard tissues in the rest of the body are formed from the mesodermal cells. Now, genetic disorders and environmental insult can alter the cranial neural crest cells and result in craniofacial malformations. Now, during craniofacial development, the cranial neural crest cells migrate ventrolaterally and proliferate to form the frontonasal process and those discrete swellings that demarcate the branchial arches. Now, this is an illustration of the neural plate, the neural tube, and the neural crest cells that migrate throughout the body, giving rise to all these structures. Now, for the development of the phase 2 important tissue structures that are needed are the pharyngeal arches and the neural crest cells. There are some prominences and the derivatives. The frontonasal prominence, the medial nasal prominence, the lateral nasal, the maxillary arch, and the mandibular arch that gives rise to the following derivatives. Now, coming to the developmental disturbances of the jaws, the list of the developmental disturbances of the jaws are agnathia, micrognathia, macrognathia, facial hemihypertrophy, and facial hemiatrophy. Now, according to the developmental anomalies affecting the maxilla, they are the cleft palate, agnathia, micrognathia, macrognathia, PIERRE syndrome, TREACHER syndrome, the craniofacial dysplasia, the craniofacial dysostosis, and the TORUS palatinus. And the mandible, agnathia, micrognathia, macrognathia, the coronoid hyperplasia, condylar hyperplasia, condylar hypoplasia, BIFID condyle, and the TORUS mandibularis. Very common deformity affecting the palate will be the cleft palate, and sometimes even the mandible is supposed to be affected with certain defects. I have a small gist regarding the pathogenesis of how the mandible is being affected during embryonic development. Human mandibular dysmorphogenesis appears in multiple congenital birth defect syndromes ranging from agnathia, micrognathia to malformations. Mandibular development depends upon interaction between the oral ectoderm and the cranial neural crest cells, derived mesenchyme within the first branchial arch. Signaling molecules, for example, the BMP, the TGF-beta, and the FGF regulate homeobox genes such as BLX, LHX, and GSC in the development of mandible. The FGF signaling is critical for the cranial neural crest cell survival, and the BMP signaling also has a critical role in mandibular morphogenesis. Loss of BMP signaling in oral ectoderm and pharyngeal endoderm will result in almost completely missing mandible to severe defects in the distal region. Hence, BMP and FGF signaling is at most important in mandibular morphogenesis. Coming to agnathia, a very rare lethal condition characterized by absence of maxilla or mandible due to failure in development of the jaw, or sometimes only one portion of the jaw may be missing. It is due to failure of migration of the neural crest mesenchyme into the maxillary prominence. In maxilla, the maxillary process and the premaxilla may be deficient. In mandible, more commonly missing will be the ramus and the condyle. Now, micrognathia, it may affect the maxilla or mandible. And mandible, probably it's described as the bird face appearance. It may be a true micrognathia, which is congenital type or acquired type or apparent micrognathia. Congenital is associated with the congenital heart disease, that is Pierre-Robin syndrome. And acquired type may be due to disturbance in the temporomandibular joint region or ankylosis due to trauma or infection of the mastoid process. Now, as clinical features, there is severe retrusion of the chin and there may be a steep mandibular angle and deficient chin button. Maxillary micrognathia due to deficiency in the premaxillary area may result in retracted middle third of the face. And mandibular micrognathia may be due to posterior positioning of the mandible or a steep mandibular angle or agenesis of the condyle. Now this is Pierre-Robin syndrome, a very classic triad which is present at birth, and the infants will have a very small lower jaw and the tongue may tend to fall backwards and downwards. Now coming to macrognathia, abnormally large jaws, pituitary gigantism, both jaws are large, and maxillary enlargement may be due to Paget's disease or DENTIN, and mandibular enlargement may be due to acromegaly. Next is a TREACHER syndrome, otherwise called as the mandibulofacial dysostosis or the first pharyngeal arch syndrome, develops during the 4th week of development, inherited as autosomal dominant and a chromosomal defect designated on the TCOF1. Now, facial hemihypertrophy or hemihyperplasia, which is an asymmetric overgrowth of one or more body parts, and significantly unilateral enlargement of the face involving the frontal bone, maxilla, palate, mandible and the alveolar process, and even the condyle and associated soft tissues, mostly on the right side. Malformation syndromes associated with hemihyperplasia are Beckwith-Wiedemann syndrome, neurofibromatosis, McCune-Albright syndrome, multiple exostosis syndrome, and sometimes even the Proteus syndrome. Now, facial hemiatrophy, which is Parry-Romberg syndrome or hemifacial atrophy, a very characteristic loss in the soft tissues of essentially one half of the face. There is a progressive wasting of subcutaneous fat, sometimes accompanied by atrophy of the skin and sometimes even the bone and the muscles, mostly seen during the first or the second decade of life, and the affected side may be hyperpigmented and typically coupe de sabre, which is a painless cleft near the midline of the face or forehead, which marks the boundary between the normal and the atropic tissues are seen. Craniofacial dysostosis due to premature obliteration or ossification of two or more sutures, and here the remarkable facial affecting the jaw bones will be a hypoplastic maxilla, and the etiology is mutation of the fibroblast growth factor receptor gene. And the other anomalies of the developmental disturbances affecting the jaw bones are the coronoid hyperplasia, the condylar hypoplasia, and the BIFID condyle. Also are TORUS mandibularis, which develops along the lingual aspect of the mandible, the cause may be probably multifactorial, including both genetics and environmental influences. These are seen as bony protuberances along the lingual aspect of the mandible above the mylohyoid line in the premolar region, and in 90% of the cases they are supposed to be bilateral. Torus palatinus, which are exostosis occurring in the middle of the vault of the hard palate, are both hereditary and environmental, and clinically they are present as bony mass that arise from the midline suture of the palate. Now this is a small illustration of the development of the palate, the premaxilla and the palatine shelves, which fuse along the midline. Coming to the cleft lip and the cleft palate, which are most common in human beings. Multiple genes are critical for the development of anterior region of the palate. For example, the MSX1, the BMP4, the BMP2 and the SHAX2 gene. SHAX2 gene loss results in cleft of the anterior hard palate, while the posterior palate may be normal. Now, the OSR1 and OSR2 are expressed in the medial lateral gradient of the developing palatine shelves. Mutation of the OSR2 gene, that is the odd skip related gene, retards the palatal shelves elevation, and expression of FGFR2 is focused on the development of the medial aspect of palatal shelf, and the mutation of this gene probably results in a complete cleft palate. Mutations of TGF beta 3 has been associated also with cleft palate, And apoptosis is clearly an important mechanism for eliminating the marginal edge epithelium during palatal formation. Now, TGF-beta and RA are critical during apoptosis in marginal edge epithelium. Though epithelial mesenchymal transformation is considered important in palatal fusion, apoptosis has been proved in elimination of marginal edge epithelium during development of palate. Now, what is cleft lip? The failure of fusion of the frontonasal and the maxillary processes, resulting in cleft of varying extent through the lip, alveolus and nasal floor. Cleft palate, the failure of fusion of the palatal shelves of the maxillary processes, resulting in a cleft of the hard and the soft palates. Two forms of clefts as inheritance may be polygenic or they may be monogenic or syndromic. Various etiology has been described as hereditary and environmental factors. It may be also related to emotional or traumatic stress, or probably a mechanical disturbance because of the size of the tongue, or sometimes there may be circulating substances such as alcohol and certain drugs and toxins in maternal blood, or infections, maternal infections, and also sometimes lack of inherent developmental force. Cleft palate, most common in the upper lip and palate region. The incidence of cleft lip and palate is about 1:800 to 1000 live births. They are described as pre-alveolar, alveolar and post-alveolar. Cleft palate extends forwards from the uvula and involves the soft palate only sometimes. The hard palate may also be involved in up to the incisive foramen. A complete unilateral cleft extending from the uvula to the incisive foramen in the midline and then deviating onto one side and meeting the alveolar process in the area of the lateral incisor and then onto the lip. A complete bilateral cleft extending forwards bilaterally from the incisive foramen to the alveolus and lip. Should be the alveolus bilaterally involved, the premaxilla remains suspended from the primitive nasal septum. Now, coming to the developmental disturbances of the teeth. A small gist on the genetic aspect. Now, cell differentiation and morphogenesis controlled by gene expression are required by body organization. Gene expression is defined as an activation of gene that results in production of polypeptides or proteins that can activate or deactivate genes with influence of the growth factors. Every organism has a unique body pattern because of the influence of the homeobox genes, the master genes that help in development of individual structures from different areas of the body. A homeobox is DNA sequence found within genes that are involved in the regulations of patterns of anatomical development, that is morphogenesis in human beings. Generally, tooth formation is genetically a complicated process controlled in two different ways. On one, by specific type, position and size, and on the other end, the process of enamel and dentin formation. Congenital absence of one or more teeth is a frequent anomaly in humans. Hypodontia, missing up to 5 permanent teeth excluding the third molars, oligodontia, absence of more than 6 teeth excluding the third molars, and anodontia, absence of teeth in both primary and permanent dentition. Genes that have been associated with anodontia, oligodontia and hypodontia being MSX1, PAX9, AXIN2, EDAI and DLX genes. Ectodysplasin signaling cascade molecules belonging to the TNF ligands are critical regulators for determination of tooth numbers in embryonic development. BMP signaling is the morphoregulator for the number, shape and size of the teeth. Overall, a continuous and reciprocal epithelial mesenchymal interaction is the key for successful tooth organ morphogenesis. Coming to number, anodontia. True anodontia, failure of development of teeth. That is total anodontia, all teeth are missing in both deciduous and permanent dentition, associated with hereditary ectodermal dysplasia. False anodontia is extraction of teeth. Now, true partial anodontia, they may be hypodontia or oligodontia, which involves one or more teeth. Now, hypodontia, commonly affected by the MSX1 and PAX9 gene mutations, and it is autosomal dominantly inherited. About 3 to 10% are the permanent teeth which are absent, and most common may be third molars, second molars, and then the lateral incisors in order of in an order. Most commonly the third molars are missing, and next common will be second molars, and then the last will be the lateral incisors. The least common will be the maxillary central incisors, they are never missing, and mandibular first molars and the canines also, and female predominance is there. And the syndromes associated with hypodontia are CROUZONS syndrome, golden hair syndrome, Ehlers-Danlos syndrome, Down syndrome, Golin syndrome, Ellis-Van Creveld syndrome, Hurler syndrome, ectodermal dysplasia, Stooge-Weber syndrome, incontinentia pigmentii, progeria, Turner syndrome, Hanhart syndrome, orofacial digital syndrome, and incontinentia pigmentii. Hyperdontia, that is more number of teeth, supernumerary teeth, 95% in maxilla, that is the anterior region. Order of predilection, maxillary incisor region, maxillary fourth molar region, mandibular fourth molar region, premolars, canines, and the lateral incise. And here you see a male predominance. And the syndromes associated with hyperdontia are Eppert syndrome, cleidocranial dysplasia, CROUZONS syndrome, Down syndrome, Ehlers-Danlos syndrome, incontinentia pigmentii, Gardner syndrome, Leopard syndrome, trichorhinophalangeal, and then incontinentia pigmentii, Gardner syndrome, and Leopard syndrome. The most common supernumerary teeth being the mesiodens, the paramolar. And they are also classified as supplemental and rudimentary. When they are supplemental, they are normal size and shape. When they are rudimentary, they are abnormal shape and small size. Other rudimentary supernumerary teeth, they are conical, tuberculate, and then molariform. One more abnormality is the dental transposition, where the normal teeth in an inappropriate position. You can see a premolar here just before the canine. A natal teeth present at birth, and neonatal, they erupt 30 days after birth. Now coming to the size. Macrodontia, more common in deciduous dentition, and the syndromes associated are the Rager anomaly, orofacial digital syndrome, oculomandibulofacial syndrome, Collin-Chowdhury Morse syndrome, and Williams syndrome. Now other factors are probably chemotherapy, chemioradiotherapy, pituitary dwarfism, and most commonly affected are the lateral incisors. This is called as relative macrodontia, and this is diffuse macrodontia. Relative macrodontia, where the jaw size is large, whereas it may be a normal size teeth, but it looks relatively small, and the teeth may look relatively small in size. Now true generalized microdontia is seen in Down syndrome and pituitary dwarfism, and Collin-Chowdhury Morse syndrome and Williams syndrome. Macrodontia, larger than normal size, megalodontia, commonly seen in the second premolars and the third molars, and diffuse macrodontia may be seen in pituitary gigantism, autodental syndrome, XYY males, and pineal hyperplasia with hyperinsulinism. Now coming to the developmental disturbances of the shape of the teeth. Gemination, otherwise called as connate teeth, or conjoint teeth, otherwise called as schizodontism. It is an attempt of a single tooth bud to divide with the formation of a tooth with a bifid crown, and usually a common root and root canal may be seen. The tooth count in the dentition may be normal. Now etiology may be trauma, vitamin deficiencies, or systemic diseases and certain genetic predisposition, and syndromes associated are achondrodysplasia and chondroectodermal dysplasia. Usually the anterior maxillary region, and sometimes in the deciduous dentition also it has been reported, and commonly affected are the incisors and the canines. Posterior primary teeth may be involved, or the premolars and the permanent molars also may be involved. Fusion, union of two normally separate tooth buds with the resultant formation of a joint tooth with confluence of dentine. The tooth counts reveals a missing tooth, which is very common in the mandible. Concrescence, union of two adjacent teeth by cementum along with the confluence of an underlying dentine, and developmental, or it may be post-inflammatory also. Areas of inflammatory damage to the roots of the teeth repaired by cementum. More common, second molar teeth with impacted third molar. Accessory cusps, cusp of Carabel, located on the mesiolingual aspect of the maxillary molars, usually seen in the permanent or even in the deciduous dentition. and accessory cusp is in mesiobuccal cusp, protostylid. Talon's cusp, it is a well delineated additional cusp surface of the anterior teeth on the lingual surface of the anterior teeth, and permanent dentition equal in sex predilection, and it may be unilateral or bilateral. Associated with Rubinstein-Taybi syndrome, Morse syndrome, Ellis-Van Creveld syndrome, incontinentia pigmentii, and the Stooge-Weber dens evaginatus, a central tubercle or a tuberculated cusp or accessory tubercle or a clusal pearl or Lyon's premolar or tuberculated premolar. A cusp-like elevation of the enamel which is located in the central groove or lingual ridge of the buccal cusp of the premolar or molar teeth. It may be bilateral mostly, and mandibular, it is predominantly seen in the mandibles. And the teeth are shovel-shaped incisors on the lingual aspect. Dens invaginatus, they are developmental variations as a result of invagination of the enamel organ epithelium before calcification, may be due to localized external pressure or a focal growth retardation and focal growth stimulation in certain areas of the tooth enamel epithelium. And mild forms are common and severe forms are rare. Coronal, it is mild, and radicular, it is severe forms. Before eruption, lumen of the invagination is filled with a soft tissue and similar to the dental follicle. On eruption, this soft tissue loses its vascular supply and becomes necrotic. Mostly seen in the permanent lateral incisors or sometimes in the central incisors. The pictures of dens invaginatus type 1, type 2 and type 3. Ectopic enamel pearl. They are hemispheric structures that may contain enamel, dentine or pulp tissue, a localized bulging of the odontoblastic layer, prolonged contact between the Hertwig's root sheath and the developing dentine. There is enamel formation in that area, and maxillary permanent molars are more than the mandibular permanent molars. The roots of the furcation area are involved, conducive to plaque retention and inadequate cleansing. Cervical enamel extension. The buccal surface of the root overlying the furcations. Mandibular molars are more frequently involved than the maxillary molars, and less frequent is the third molars. Associated with developmental or inflammatory cysts leading to periapical cysts, the buccal surface over the bifurcation, you find the buccal bifurcation cyst being formed. Taurodontism, a bull tooth. Enlargement of body and pulp chamber of a multi-rooted tooth with the apical displacement of the pulpal floor and bifurcation of the roots. Etiology being failure of the Hertwig's epithelial root sheath to invaginate at the proper horizontal level. They may be unilateral or bilateral, and there is no sex predilection. Classification are normal, cyanodont or hypotaurodontism, mesotaurodontism or the hypertaurodontism. Syndromes associated with the taurodontism are amelogenesis imperfecta, hypoplastic type 1E, amelogenesis imperfecta taurodontism type 4, and cranioectodermal dysplasia, Down syndrome, ectodermal dysplasia, Ellis-Van Creveld syndrome, and hypophosphatasia or hypophosphatasia, Klinefelter syndrome, trichodento-osseous types 1, 2 and 3, or oculodentodigital dysplasia. Dilaceration, abnormal angulation or bend in the root or less frequently the crown of the tooth. Etiopathogenesis, injury displaces the calcified portion of the tooth germ and the remainder of the tooth is formed at an abnormal angle. Common site is the apical third of the anterior or premolar tooth and the middle third of the molars and the cervical thirds of the third molars. Crown dilaceration in maxillary central incisors may be seen. Syndromes associated with dilaceration are Smith-Magenin syndrome, Ehlers-Danlos syndrome, Axenfeld-Rieger syndrome, and congenital ichthyosis. Developmental disturbances of the structure of the teeth. They are the amelogenesis imperfecta, environmental enamel hyperplasia, dentinogenesis imperfecta, dentin dysplasia, and the regional odontodysplasia. Amelogenesis imperfecta. Now, researchers have described at least 14 forms of amelogenesis imperfecta. They may occur alone or as a part of a syndrome. Mutations in the MLX, ENAM, MMP20, and FAM83H genes cause amelogenesis imperfecta. The AMLX gene, ENAM, MMP20 and FAM83H give instructions for making proteins for normal tooth development in the formation of enamel. In most cases, males with X-linked amelogenesis imperfecta experience severe dental abnormalities than females. Now, type 1 hypoplastic, type 2 hypomaturation, and type 3 hypocalcified, and type 4 hypomaturation are the different types, the classification. Now, hypoplastic, a generalized pattern, inadequate deposition of enamel matrix, pinpoint pits to pinhead-sized pits scattered across the buccal surface of the teeth, and staining of these pits may occur. The enamel between the pits are of normal structure. Localized patterns, horizontal rows of pits or linear depression, and they are seen in the middle third of the buccal surfaces of the teeth. Coming to hypomaturation, the enamel matrix begins to lay down appropriately. Defect in maturation of enamel crystals. Teeth are normal in shape but may be mottled, opaque or brown yellow discoloration, and they tend to chip away from the underlying dentin. Hypocalcified, the enamel matrix is laid down appropriately but no significant mineralization occurs. Teeth are appropriately shaped but enamel is very soft and easily lost. On eruption, the enamel is yellow, brown or orange and may get stained brown to black. Environmental enamel hypoplasia, they are incomplete or defective formation of enamel organic matrix of teeth. Causes may be due to local infection or trauma, that is Turner's teeth or Turner's hypoplasia. That may be due to infection to the primary teeth that leads to periapical area where ameloblasts of the secondary tooth buds are present. Otherwise, congenital syphilis is another cause, birth injury and ingestion of chemicals like fluoride. Turner's hypoplasia, a type of hypoplasia occurring occasionally seen involving a single tooth, usually the permanent maxillary incisors or maxillary or mandibular premolars. Any degree of hypoplasia ranging from mild brownish discoloration of the enamel to a severe pitting and irregularity of the tooth crown. Etiology, the deciduous tooth becomes carious during the period of growth when the crown of the succeeding permanent tooth is being formed. The bacterial infection involving the periapical tissues of this deciduous tooth causes trauma to the erupting permanent tooth, and hence there is enamel hypoplasia. Clinical features, yellowish or brownish stain or pigmentation of enamel usually on labial surface, or as a true hypoplastic pitting defect are also seen. Congenital syphilis involves maxillary and mandibular permanent incisors and the first molars. Anterior teeth affected, the Hutchinson's incisors screwdriver shaped and the incisal edge notched incisal margins, and molars are mulberry molars, otherwise called as Moon's molars or Fournier's molars. The crowns are irregular and the enamel of the occlusal surface and the occlusal third of the tooth appears to be arranged in an agglomerate mass of globules rather than regular formed cusps. This is the Hutchinson's incisors and the mulberry molars. Next is fluorosis. This type of enamel hypoplasia results due to excessive ingestion of fluoride from the drinking water. Severity of mottling increases with increasing amounts of fluoride. Pathogenesis, due to disturbances of the ameloblast during the formative stage of the tooth development, the enamel matrix is defective or deficient, and interference with the calcification processes of the matrix because of excessive fluoride in the drinking water. Clinical feature, appearance of mottled teeth, occasional white flecking or spotting of enamel may be seen, or it may be seen as white opaque areas, and moderate to severe changes showing pitting and brownish staining also, and sometimes it may have a corroded appearance. Next comes the dentinogenesis imperfecta. Type 1 dentinogenesis imperfecta without osteogenesis imperfecta, broad crowns with cervical constriction. The DSPP at gene map locus 4q21.3 encoding dentin phosphoprotein and dentin sialoprotein is mutated. Teeth are blue-gray or amber brown and opalescent. Opalescent teeth. Type 2 dentinogenesis imperfecta, Shields type 3 or the Brandywine type dentinogenesis imperfecta, otherwise known as the shell teeth, The mutations with the genes affected are the DSPP, DMP1 and 1 BSP and SPP1. Inherited as autosomal dominant, the dentin is amber and smooth, and multiple pulp exposures are seen. Normal, non-mineralized pulp chambers and canals and general appearance of a shell teeth may be seen in radiograph. Histological features: the enamel may be normal, but the dentin are irregular tubules made up of irregular tubules, often with large areas of uncalcified matrix, and tubules are larger in number, and cellular inclusions, probably the odontoblasts, are entrapped, and which gives the appearance of osteodentin, described as osteodentin. Dentin dysplasia or rootless teeth is a rare disturbance of dentin formation characterized by normal enamel but atypical dentin formation with abnormal morphology. Now, Shield and his associates classified it into type 1 and type 2 dentin dysplasia, and Whitcomb referred it as radicular and coronal type of dentin dysplasia, inherited as autosomal dominant. Type 1, that is radicular, a slight amber translucency, exfoliated prematurely on or after only a minor trauma. There may be a delayed eruption and extreme mobility may be there, and roots are short, blunt, conical or similarly malformed. Radiographic features: obliterated pulp chambers and root canals. A new dentin forms around obstacles described as lava flowing around boulders. Type 2, yellow-brown or bluish-grey opalescent. Clinical appearance of permanent dentition is normal. Radiographic features: the pulp chamber is obliterated and pulp stones may be seen, and probably abnormally large pulp chambers in the coronal portion of tooth, giving rise to a thistle tube appearance of the pulp. Physiological features: amorphous and tubular dentin in the radicular portion, while coronal is relatively normal. Pulp has multiple pulp stones or denticles. Regional odontodysplasia. Odontogenic dysplasia or odontogenesis imperfecta or ghost teeth. One or several teeth in a quadrant are affected. Common will be the maxillary teeth, the central incisors, lateral incisors and premolars, and it affects both the deciduous and the permanent dentition. Associated with vascular nevi of overlying facial skin sometimes, probably a vascular etiology defect. An etiology is a somatic mutation or a latent virus residing in the odontogenic epithelium during development, and the clinical features: affected teeth exhibit delayed or total failure in eruption and abnormally shaped, altered, irregular in appearance with defective mineralization. This is the picture, and this is described as a ghost tooth appearance because of the thin enamel and dentin with the abnormally large pulp chambers.